I'm Dr. Michael Carlton. What we're going to talk about today is treating opioid dependence. And one of the medications that can be used to treat opioid dependence is called buprenorphine. It comes as a tablet form in the form of Suboxone or Subutex. It comes as a film strip form. Looks a little bit like a Listerine film strip, and you just kind of pop it underneath your tongue and it dissolves. But the newest form of the medication is much safer and much less likely to be abused, and certainly can't be shared with other people because it's an implant. And it goes right here, right underneath the skin of the arm. It's inserted just through a needle. We numb up the skin for you. We put 4 little implants in there. And then once those implants are in, it's great because one of the things that can happen is you can't forget to take your medication. So this way you don't have to worry about taking a pill every day. Another thing that can happen for some people is they start thinking, well, you know, I don't think I need this medication anymore, and they start weaning themselves back, and before you know it, they're not taking the medication, and then they start thinking about using. And then last but not least, the other thing is for somebody to say, I just want to go get high. And if I want to go get high, I can just stop taking my pills, and in a few days I can go do that. But with this, you can't do that because the medication is implanted right underneath the skin, and it would have to be taken out. First you numb up the skin, then you make 4 little lines in the area where we're going to put the implants. Once the skin is numb, we go in with a needle. The needle has what's called a little trocar in it. You pull that trocar out, you insert the implant, then you put it in, kind of push it through most of the way, put your finger over the end of it, and then the implant stays right there. It only takes about 5 minutes to put the implants in. There's only a small little 1/4 inch incision, so you don't need to have any sutures or anything. We just put a steri strip across it, and then we're done. Once that's in, it's a great thing because now you've got a medication on board that does several things. Number one, it decreases thoughts of using and cravings. So for people who are having cravings, this decreases that. People who have cravings are more likely to start thinking about using. If they're more likely to think about using, they're more likely to go out and use. With methadone, if I use methadone, number one, methadone may actually get me high. Number two is if I use on top of methadone, I will be able to feel some of the effects, most of the effects in fact, of whatever I use. It'll blunt the effect of what I use, so if I use heroin or Percocet or Vicodin on top of methadone, it'll blunt the effect a little bit, but I'll still be able to feel it. On the other hand, if I'm using buprenorphine, particularly in the form of this implant, Probuphine, if I'm using that implant and I have it in, and then I go out and use, guess what? I can't get high. I can't get high because it blocks the effects of opiates. So that's one of the things that we can use it for, and it works really, really well. We've had a great success rate here at A Better Today using this medication, allowing our patients to stay involved in treatment, to be able to work their steps, to work with their sponsor, to work in recovery, to work with their counselor or therapist, whoever they're working with, in order to maintain and obtain long-term sobriety. So using buprenorphine has been a great boon to treatment. It allows people to not think about using, not have cravings for using, not have thoughts about using, and most importantly, it allows people to stay abstinent. Remember that medications can help you maintain abstinence, but it's all the work you do afterwards, the work you do with your sponsor, the work you do in a 12-step meeting, in Celebrate Recovery, in Rational Recovery, in Smart Recovery, the work you do with your counselor and therapist. That's the work that helps you get to recovery. Medications can't help you do that, but if you're using, you can't get there. So that abstinence that medications help you attain is a great thing. These medications may last anywhere from 2 to 4 weeks. We're waiting for those to be approved, and as these medications get approved and as we continue to use this, we are seeing more and more and more success with our clients who leave A Better Today and are able to go out and maintain and obtain long-term sobriety. So when we talk about any kind of medication, what we have is what we call as a dose-response curve. And in a dose-response curve, you see the bottom line is the dose of a medication, how much medication the patient is taking. That could also relate to drug. And the sideline is the effect or the response that you get from the drug. And so with any drug, whether that's aspirin or Tylenol, whether that's Percocet or Vicodin, if you're talking about other kinds of illicit substances such as cocaine, amphetamines, methamphetamines, or even if you're talking about something as simple as penicillin antibiotics, the more you take, the more effect you get. And so as you take more, you continue to move up that curve until you get to a place where more medicine just doesn't give you any more benefit. All medicines work by binding to something in your body. You have receptors for these things. And once all of those receptors are all bound up, taking more medicine can't give you any more effect. So there's always a plateau. Now the problem with addictive substances, there are some medications that are not addictive that do this, but all the addictive substances do that, is over time, the more you take, the more you need. You start developing tolerances. And so if I want to get high with the medication, if I want to avoid overdose, if I want to get pain control, whatever that effect I need, it's over time I may need to have more and more and more medication to take that. And so what you see here is you're sliding to the right and you're developing some tolerance in this curve. Withdrawal is actually the opposite. Withdrawal is your slide back. It's that tolerance going away. And it's that withdrawal process that gets people withdrawal symptoms. Now, a medication that does this, we call it an agonist. It's like walking into the room and turning the lights on. With the lights fully turned on, you got the full effect. And that full effect may be pain management. That full effect may be getting high. If you take too much, that full effect may be overdose. There's a second kind of medication, and that medication is called a partial agonist. And like the agonist, the more you take, the more you get, but it has a much lower ceiling. Buprenorphine, in the form of Suboxone, Subutex, other brand names, as well as our implant Probuphine, falls into this category. And there are several reasons why it's important. The first one is that, as you see, the plateau is below the place where you can get high. So for the vast majority of patients, particularly if they've been using relatively recently, our patients aren't going to get euphoric, aren't going to get a high when they take it. Some people, if they haven't been on opiates in a while, if they take a big enough dose of this, they can experience a little bit of euphoria for a short amount of time, but the vast majority of opioid-dependent patients will say this just doesn't do much to get them high. The second important thing is that, as you can see, the plateau is clearly lower than the place where you would overdose. And so it's almost impossible to overdose on this medication. The last thing that is important about this medication is, unlike methadone, is if you're taking methadone and then you go out and use Percocet, Vicodin, and heroin on top of that, you'll feel the effects of the Percocet or the Vicodin or heroin. It will blunt it a little bit, but yes, you can still get high with those medications. The advantage of using buprenorphine in this setting is that in addition to not giving you enough to make you high, it actually blocks the effects of other opiates, so once again you can't get high. Now, the disadvantage of either methadone or buprenorphine in the treatment of opioid dependence is they are both opiates. One is a full agonist, like turning the lights on. Buprenorphine is a partial agonist, like turning the lights halfway on. And once those things are halfway on, now what I do is I break the light switch so that nobody else can adjust it, because again, if I go out and use on top of that, I'm not going to be able to get high. But when it comes time to stop, you still really need to wean yourself down. With methadone, that can take a long time. Typically, for people in methadone programs, we wean them down over 6, 9, 12, 18, sometimes as much as 24 months to get them completely off of their methadone. With Suboxone, it doesn't take that long, but still, we're typically going to do it over 4, 6, or 8 weeks, because if not, you start to have opioid withdrawal symptoms. If you start to have opioid withdrawal symptoms, it can induce cravings, thoughts of using, and it can trigger relapse. We want to make sure we avoid that. Now, the last type of medication we use to treat opioid dependence is the bottom line of that thing. And what that bottom line on the graph says is that no matter how much medication you take, you get no effect. A logical question at that is if I don't get anything, why would I bother taking the medication? Well, it depends on how you define effect. If you define effect as turning the lights on, this is like leaving the lights off. But because it's also like breaking the switch at the time that you're using it, it means you can't get high. So if you go out and use Percocet, if you use Vicodin, if you use heroin, you use methadone, you use any of these other substances, opioid substances on top of that, then what happens is you can't get high. And the advantage of Naltrexone, in the form of a shot, it's also called Vivitrol, a once-a-month shot. The advantage of this is it's not an opiate. So it doesn't matter how long you stay on it. You could be on it for days, weeks, months, and years. When it comes time to stop, all you have to do is stop. Because when you stop the medication, there is no opioid withdrawal because it's not an opiate. Prior to the development of medications, and medications have been around to help people maintain abstinence since 1986, everybody who ever got clean and sober did so without medications. So on a regular basis I hear, well, I got sober without medications, so why shouldn't everyone else get sober without medications? Well, there's a couple reasons for you to think about using medications. Number one is, if you come to treatment, we would never say, now that your treatment's done and you've been in our program for 30 or 60 or 90 days, we always include things that you should be doing after you leave our care to continue on in your treatment. People need to be in a treatment program for somewhere between 3, 6, 9, 12 months, even longer for many people, people who particularly have been doing substance abuse for decades sometimes. Trying to do treatment in a 30 or 60, 90-day place just really doesn't work very effectively. The thing that medications can do is increase your abstinence rates. And if you increase your abstinence rates, if you're not using, you are much more likely to go home and stay clean and sober. If I'm using, I tend to not go to my meetings. I tend not to go see my counselor. I tend not to see my therapist. I don't call my sponsor. I don't call my accountability partners. But if I'm not using, I'm much more likely to stay in contact with the people around me who are holding me accountable and helping me to maintain my abstinence and sobriety. Medications really are an important part of this. Now, which medication should you use? That depends. I think that anybody who has never gone through treatment before certainly has a right to try to do this in a medication-free way. However, if you do that, what I'm going to tell you is you are still somewhere between 100 and 400% more likely to go out and relapse if you're not taking medications. With anything that you would do, if you could double or triple or quadruple your success rate, you would do it. Certainly with medications, that's what we see. The next thing is which medication should we choose? For opiates, for example, there's naltrexone, which is not an opiate, does not cause withdrawal. There's buprenorphine in its many forms as a tablet, a film strip, a film that goes onto the inside of your cheek, or an implant that you can put underneath your skin and in development as a shot. And then there's methadone, which is available as a tablet or liquid which you can use. My own feeling is that we should always start with the medication that is the least invasive. And so for me, the least invasive medication is naltrexone. Naltrexone is an opioid blocker. As we've talked about in a different place, an opioid blocker is something that simply blocks the effects of opiates. You don't get any opiate effects, so you could be on it for as long as you want, and when it comes time to stop, there is no withdrawal. The other advantage that naltrexone has is if you happen to be addicted to opiates and alcohol, naltrexone can work for both alcohol and opiates. The other medications that we use for opiate dependence only work for opiates. They don't work for anything else. The second thing you can use is buprenorphine. Buprenorphine is that middle line curve that we talked about. The nice thing about buprenorphine is that for the vast majority of people who use it, there's no high, there's no euphoria. Then another thing that's great about buprenorphine is it blocks the thinking about using. So I'm not having thoughts of using, dreams about using. I'm not having cravings for using. And if I'm not having those thoughts and dreams and cravings, I'm much less likely to go out and act on the impulsivity of using. And on top of that, and most importantly, it decreases the actual effect of using. So that I'm not going out to use, and if I did use, I'm not going to get high anyway because it's going to block the effects of those opiates. So I've come to treatment because I want to get clean and sober. In addition to doing that, coming to treatment, I'm doing all the work. I'm seeing my sponsor, I'm working my steps, I'm working through the Smart Recovery book, I'm working through some other program that my therapist has done with me. I'm doing lots of different things to help myself stay clean. By doing those things, I dramatically increase my rates of success so that I can go out and not use. Again, by using medication and adding medication to that, I double, triple, and quadruple my success rates over and above anything that I would do with treatment. The last form of medication, and what I would say is the most aggressive or the most intensive form of medicine, is methadone. Methadone can be a really good medication, but for a lot of reasons, it can be very hard to use. Number one is if you're in a methadone treatment program, you have to go to the methadone treatment program 6 or 7 days every week to get your dose. Once you get your medication, you take the dose there, and you don't get any medication to take home. So that means it's not something that you can share or abuse. On the other hand, for many methadone treatment programs, there are a lot of programs that I would refer to as juice bars. In juice bars, you go in, you take your medication, you drink it, you go down, you walk out, and you're done. A good methadone treatment program makes sure that you are continuing to be involved in treatment, that you're seeing their therapist, you're seeing their psychiatrist, you're seeing their doctor, you're going to 12 steps, you're doing smart recovery, rational recovery, again, something for ongoing treatment. Because it's the treatment in the long term that really allows me to get recovery. And once I get recovery, then I can start weaning down on my methadone. One other disadvantage of methadone is when it comes time to come off, I can get you to a high dose pretty quickly, but when it comes time to stop the methadone, we're going to come down really, really, really slowly. And for most people, that means minimum of 3 months, and more typically 6, 9, 12, 18 months to wean you off of methadone.
Thank you for watching. Please be sure to like, comment, and subscribe. Also, check out more of our videos from ABT.